The concept of personality is somewhat modern, and we can look through history to find analogies of the concept as early as 142 AD. Greek physician and philosopher Galen wrote about the humoral theory of human illness and adapted it to consider human character as well. His hypothesis stated that the four primary human bodily fluids, which he identified as blood, phlegm, black, and yellow bile, could, in their excess or deficit, cause human illness, or, as he proposed, could also define an individual's character. The 19th century saw developments in the concept of personality coming from Gerhard Hamann and Emil Kraepelin. Hamann conceived of a cube model of personality, where the three dimensions of his cube model represented aspects of human behavior, which included activity, emotionality, and spontaneity. And depending on the excess or deficit of those particular aspects, the corners of the cube, 8 in total, represented personality types. And those included the amorphous, sanguine, nervous, choleric, apathetic, phlegmatic, sentimental, and passionate personality types. And you may have noticed that 3 of those were adapted from the prior humoral model of human character. Emil Kraepelin brought personality into the psychological literature by identifying what he labeled psychopathic personalities. By looking at how personality could negatively influence an individual's experience and behavior, he identified 4 personality types which we likely wouldn't stand beside today, including the born criminal, the weak-willed, pathological liars, and he also identified paranoid personality. Kraepelin's conception of personality was accompanied with an idea of etiology, which was a sign of his time, where in the early 1900s, they still adhered to an idea of racial degeneration. This concept that somehow mixing races could induce negative health outcomes and negative behaviors from individuals. We're going to continue to look at the growth of the concept of etiology for personality throughout this presentation and how new lenses have been applied to human behavior and this idea that human behavior has long-standing consistency, but by far, Kraepelin's application of degeneration theory to personality is far and above the most harmful. In the early 1950s, when the first DSM was published, Raymond Cattell was contributing to the psychological literature by observing the English lexicon for adjectives describing human behavior and human personality traits, and a grand total of over 14,000 adjectives were compiled, and this lexicon was observed to basically factor down common themes throughout these traits to find the various ways that human behavior could be described and conceptualized. He narrowed them down to 16 factors into a model which we still use today called the 16PF, standing for the 16 personality factor model. Cattell's empirical approach was adopted by many research teams after his time, and the most popular model of personality we share today is the 5-factor model. And it reduced a list of 1,700 personality descriptors to only 5 factors. The acronym OCEAN includes all 5 of them. That's openness to experience, conscientiousness, extroversion, agreeableness, and neuroticism. It's important to note that this theory of personality is derived from the English lexicon, and it couldn't be more clear that this concept of personality and its adaptation into the idea of pathology has a very Western focus and takes a very Western approach to understanding individuals and understanding their problems. Today, the DSM categorizes personality disorders into 3 clusters, including A, B, and C. And the cluster C personality disorders align with an experience of fear and anxiety. there's a common factor of negative life experiences that accompany these disorders, and we'll view those negative life experiences through three lenses. And those are the attachment lens, looking into early relationship quality, the psychodynamic lens, which will look for profound dysfunctions and conflicts in childhood, and finally the cognitive lens, which will analyze maladaptive schemas and beliefs. The cluster C personality disorders include avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. And the cluster C personality disorders are observed to be less severe than those in clusters A and B in terms of their impact on functioning, both in relationships and occupations. And among the three cluster C disorders, obsessive compulsive personality disorder is generally considered to be the most severe, though this is contested. I'll give a brief overview of some common factors that have been observed to have associations with each of these three disorders. And it's not to say that the factors of childhood experience that I'm going to list or cognitive schemas that I'll also include necessarily cause the experience of these disorders or cause the behaviors that have been categorized into these personality disorders, but rather considering that populations have been observed to show these behaviors and the DSM has categorized them under this diagnosis, we've seen those populations associated with particular childhood experiences and particular cognitive schemas. And beginning with avoidant personality disorder, we see associations with physical abuse in childhood, sexual abuse, and emotional abuse. We observe emotional neglect and bullying as common factors, as well as low parental affection and lack of nurturing. For avoidant personality disorder, we also observe cognitive schemas such as the world is harmful and others can be hostile. Dependent personality disorder is observed to have associations with physical and sexual abuse in childhood, as well as a controlling dynamic within the family and rule-based systems and authoritarian parenting. Cognitive schemas that are associated with dependent personality disorder have a theme of low personal efficacy and a feeling of low competence. For obsessive compulsive personality disorder, it's important to point out that 8 criteria make up the diagnostic label and only 4 criteria need to be met. And considering that only 4 of 8 need to be met in order to group individuals under this diagnosis, you're going to see a greater variety in the behaviors expressed. And we can take that heterogeneity, that distinction and difference between OCPD individuals, and understand how it's difficult to draw associations between them and particular childhood experiences or particular schemas. However, weak associations do exist under particular studies, and the themes of those associations are general abuse, sexual abuse, and verbal abuse in childhood. Before investigating the 3 cluster C disorders individually, I'd like to recap some of the implications of what's been covered so far and place a central focus on the idea that personality as a concept is subjective, and its definition, as stated by the APA, it's referred to as the enduring characteristics and behavior that comprise a person's unique adjustment to life. It hinges on the notion of personality being consistent or stable over time. And research has shown that, in fact, personality can change with major life events and changes throughout phases of individuals' lives. It changes with people's environments and their connections and relationships. The major life events that are most shown to cause changes in personality include the beginning and ending of relationships, having children, and major shifts in one's occupation. I say this so that we can take a critical look at defining people according to their personality and these pervasive symptoms to better understand what might cause the behaviors that they're experiencing. Does it come down to personality, or does it come down to life experiences? And if we're going to consider personality in our conception of our clients, do we consider it as an inherent trait or as an adaptive trait that's evolved with their environment and their experience? Within the theoretical camp of inherent personality, we'll find countless studies of heritability relating to really any disorder within the DSM. The DSM diagnostic labels are applied to populations, and at that point, researchers are free to engage in genetic studies of those populations. But leaning into an idea of an inherent personality and appealing to heritability of an experience like a personality disorder attributes genetic cause, where there's so much more understanding to be gained through one's experience of life and one's adaptations, both through the cognitive lens of what their internal beliefs are and the attachment lens of how their relationships developed in early childhood and going into adulthood. Understanding that we're going to engage with a diverse set of clients in our future practice, we should understand what systemic factors could cause the experience of these disorders. In the case of avoidant personality disorder, what systemic forces could cause an individual to have a fear of rejection? How could microaggressions and discrimination and being made to feel other in a population of broadly white, cisgender, heterosexual men and women of binary gender, how could that instill a fear of rejection in an individual? For dependent personality disorder, a fear of failure and incompetence. When we don't adapt well to the systems of occupation, the systems of education that are structured within our Western society, we're left feeling useless and like we're deficient in various ways. There are many broad systems that we live in and have to function in that can induce this fear of failure and incompetence. And finally, obsessive compulsive personality disorder is defined by an anxious need for control. We can understand how systems of education and occupation introduce this demand for compliance and assimilation, but also in parenting, where children are vying for security and closeness and belonging. If a parent withholds warmth and nurturance in order to obtain a child's compliance, we can understand how that child might develop a disposition and a worldview that control over the self and control over details and minutia might be their best bet at obtaining relational security. Avoidant personality disorder is defined according to 7 criteria, and those include avoiding occupational activities involving significant interpersonal contact, and that's out of fear of criticism, disapproval, or rejection. 2 is an unwillingness to get involved with people unless they're certain they'll be liked. Criterion 3 shows restraint with intimate relationships, and that's out of a fear of being shamed or ridiculed. Criterion 4, they're preoccupied with criticism or rejection in social situations. Criterion 5 is inhibition in new interpersonal situations, and that's out of a feeling of inadequacy. Criterion 6 is a view of the self as being socially inept, being personally unappealing, or even inferior to others. And the final 7th criterion is an unusual reluctance to take personal risks or engage in new activities, and that's out of a fear of embarrassment. In order for these criteria to be considered diagnostically sufficient, they have to be pervasive over time and relatively stable. We'll find that there are themes of shyness, being timid, lonely, and isolated, and we find that these feelings occur in both social and occupational functioning. Also, the onset of these symptoms for an individual meeting the criteria must be within childhood or adolescence at the latest. The DSM offers cultural considerations around differences in interpersonal openness and how avoiding social situations may be appropriate in particular cultures, especially in the face of embarrassment. One might reserve oneself from social interaction, as they say, to preserve social harmony or to prevent public offense. And we have to understand the underlying cause of the isolation and avoidance in order to determine whether we're looking at a personality characteristic meeting diagnostic criteria or a culturally appropriate response. Of the 7 criteria listed, only 4 need to be met in order to assign a diagnosis of avoidant personality disorder, and 4 of 7 offers quite a bit of leeway for heterogeneity within the avoidant population, though not to the level of obsessive compulsive, which requires 4 criteria out of 8 to be met. The DSM provides information on the prevalence of this disorder within the United States. It was shown to be 5.2% of the population in the National Comorbidity Survey replication, whereas a review of 6 epidemiologic studies within the U.S. found a median prevalence of 2.1%. Prior to the introduction of the DSM in the early 1900s, schizoid personality disorder encapsulated the symptoms of isolation and shame that we find in avoidant personality disorder. And it wasn't until DSM-3 in 1980 that these symptoms were categorized under the personality disorder that we find it today. In this same version of the DSM, we see the division of axes separating axis 2, containing all personality disorders, from the rest of the diagnostic manual. And this separated avoidant personality disorder from the similar body of symptoms under social phobia. The DSM-3R in 1987 saw a shift in this diagnosis toward the psychoanalytic concept of the phobic character, and we see that in criterion 1 with occupational avoidance out of fear of criticism or disapproval, as well as the criterion regarding social phobia, inhibition due to fear of embarrassment. Finally, the DSM-4 brought us up to date with our current criteria model of avoidant personality disorder, with the addition of viewing oneself as socially inept, personally unappealing, and inferior to others. While we mentioned earlier how obsessive compulsive personality disorder is conceived of as the greatest severity among cluster C disorders, other sources cite that avoidant personality disorder can have the highest impairment in daily functioning due to the cause of mental distress, low sense of self-efficacy, and can lead to lower education outcomes, lower income, and accepting unpaid work. The social isolation that accompanies the disorder has a downstream effect of impacting mental health from many angles because of our basic need for human contact and a sense of belonging in order to gain mental health. The disorder is characterized by a sense of internalized shame and the resulting social anhedonia, the inability to derive satisfaction, enjoyment, and excitement from social engagement, is what we can look to explain the pattern of isolation that avoidant individuals suffer from. Risk factors contributing to this disorder include a parenting style that's critical and rejecting, and associations have been found in research to emotional neglect in childhood. Treatment recommendations for avoidant personality disorder often include cognitive behavioral therapy with the aim of addressing the cognitive distortions underlying the experience of shame. It addresses the process of emotion that begins with the negative feeling associated with one's social worth and one's individual value, and that is followed by a distorted cognition about the self, and the personal belief finally results in an overall belief about oneself that is experienced through shame and a sense of inferiority. Another study observed the impact of graduated exposure to social environments in comparison to skills practice, and concluded that skills practice did not result in relief of symptoms after the term of treatment, whereas graduated exposure in those social environments elicited a reduction in symptoms and also a reduced tendency toward isolation. Another study found that a psychodynamic approach was effective for this population using a protocol called intensive short-term dynamic psychotherapy, and it was found not only to be efficacious in the treatment of symptoms, but also cost-effective due to the short-term nature of the treatment. Assessing this disorder can take place in the form of a structured interview, though it's recommended to obtain both self-report and observer report measures. Observer report measures were shown in a meta-analysis to be at least 25% more accurate in terms of internal consistency than self-report measures. And when it comes to the heterogeneity of the avoidant personality disorder population, considering it only requires 4 of the 7 criteria in order to diagnose, there's a lot of room for overlap with other disorders that are non-personality related. And even within the cluster C personality disorders, there is overlap in the understanding of particular behaviors. A highly recommended assessment tool that falls within the category of self-report measure is the TEMAS Narrative Survey, which stands for Tell Me a Story. TEMAS is Spanish for themes, and this assessment tool allows clients to open up with a more personalized conception of the meaning behind life experiences, shaping their symptomatic behavior, and adding dimension to the assessment quality of self-report measures. Dependent personality disorder is characterized by a pervasive need to be cared for and can result in submissive or even clinging behavior. It's motivated by a sense of being incompetent or not able to take care of oneself. There are 8 criteria, and of those 8, 5 need to be met in order to make the diagnosis. And they include having difficulty making everyday decisions without excessive advice and reassurance from others. The second is needing someone to assume responsibility for major areas of your life. The third is having difficulty expressing disagreement with others out of fear of losing their approval or their support. The fourth is having difficulty initiating projects or getting things done without others' assistance, and it's out of a lack of self-confidence in their judgment or their abilities, and it doesn't pertain to a lack of motivation or energy, which you might expect from a mood disorder. The fifth criterion is going to excessive lengths to obtain nurturance and support from others, and they may even volunteer to do unpleasant things to gain that support. Criterion 6 is being uncomfortable or helpless when alone, and it's out of an exaggerated fear of being unable to care for oneself. Criterion 7 is urgently seeking other relationships as a source of care and support after a close relationship ends. And the final 8th criterion is an unrealistic preoccupation with fears of being left to take care of oneself. Prior to its inclusion in DSM-3, the symptoms of dependent personality disorder would have been categorized under other personality disorders of unspecified type in the DSM-2 as early as 1968, and they were categorized under a particular disorder in DSM-3 in 1980, and it was defined by 3 broad criteria, and those included passivity in interpersonal relationships, a willingness to subordinate one's needs for others, and also to lack self-confidence. The 2013 DSM-5 nearly did not include dependent personality disorder as a result of the personality disorder work group advising its removal. The American Psychiatric Association Board decided not to abide that recommendation, but you can understand the work group's reasoning when we look at the prevalence of dependent personality disorder, which is identified in only 0.6% of the national population in the National Comorbidity Survey replication, and that's a pretty consistent measurement across various prevalence measures for this disorder. We should also consider how dependency is culturally dependent. And Western society is particularly focused on productivity, individual achievement, and separation from the family, where dependent behavior that is viewed as excessive by Westerners might be completely acceptable and even recommended in other cultures. We should also consider the heterogeneous presentation of dependent personality disorder and how only 5 of 7 criteria are needed to receive the diagnosis, and so we'll likely see a very different presentation between two individuals experiencing the disorder. Factor analysis identified 2 separate domains of the experience of dependent personality disorder, and those were incompetence and dysfunctional attachment. The incompetence refers to the thoughts of the self as being unprepared to take care of themselves and relying on others, whereas dysfunctional attachment refers to the breakdown of relationships as a result of excessive expression of need and dependence. Risk factors contributing to the disorder include parenting that's described as overprotective and authoritarian. Overprotection can introduce a learned behavior of dependence, whereas authoritarian parenting can be so dismissive of a child's abilities and introducing so much rejection and criticism into the relationship that the individual starts to doubt their capacities and has a negative emotional response to encountering responsibility. Self-report measures that are recommended for assessment include the Interpersonal Dependency Inventory, the Dependent Personality Style Scale, and the 5-Factor Dependency Inventory. But it's recommended to have free response measures as well to add accuracy to the diagnosis. And this could include the TAMAS narrative survey that we mentioned earlier. The treatment potential for DPD individuals is actually quite good, considering that they're often eager to please and will comply with the goals of therapy. They'll ask for guidance and look for insight from the support figure of the therapist. But it should be noted that the ambivalence to becoming autonomous and taking responsibility for oneself, that's a primary goal of treatment for DPD, bringing that ambivalence into conscious awareness. Behavioral therapy is recommended to address the fears underlying the dependent behavior. A major goal of behavioral therapy would include desensitizing the individual to rejection and abandonment and introducing adaptive responses in those interpersonal circumstances. Cognitive therapy, on the other hand, would address the maladaptive schemas that are informing the dependent behavior, and that would center around the idea of self-efficacy and driving positive beliefs toward one's personal abilities. Finally, obsessive-compulsive personality disorder describes a pervasive pattern of being preoccupied with orderliness and perfection and having a mental and interpersonal control. This is at the expense of one's flexibility and openness and their ability to be efficient. This begins in early adulthood and is seen in a variety of contexts, including interpersonal and occupational. There are 8 criteria, and only 4 are needed to meet the diagnosis, making obsessive-compulsive personality disorder the most heterogeneous, meaning the most diverse expression of symptomatic behavior in the identified population. Those 7 criteria include being preoccupied with details and rules and lists, a preoccupation with order and organization, and schedules, and that's to the extent of the point of the activity getting lost on the individual. The second criterion is showing perfectionism interfering with your task completion. The third is an excessive devotion to work and productivity, and that's to the exclusion of leisure activities and friendship. The fourth criterion is an overconscientiousness and an inflexibility on matters of morality and ethics or values. The fifth criterion is an inability to discard worn-out or worthless objects, even when they don't bear sentimental value. Criterion 6 is a reluctance to delegate tasks or to work with others unless they can submit to exactly their way of doing things. Criterion 7 is adopting a spending style that's miserly toward oneself and others, and viewing money as something to be hoarded for future catastrophes. And the final eighth criterion is a rigidity and stubbornness. OCPD is the earliest of the cluster C personality disorders to be introduced to the DSM, as it appeared in the first edition in 1952. While it's remained relatively consistent in the DSM editions since that time, it did appear in a different form in an earlier work by Pierre Janet in 1903, where he wrote about obsessions and psychasthenia. Psychasthenia represents the failure to adapt to reality, which Janet identified, whereas the obsessions were characterized as forced agitations in his work. The aspect of failing to adapt to reality centers around their fixation on particular outcomes in order to gain a sense of security, and this can become a target for treatment in cognitive behavioral therapy. The prevalence for the identified population of obsessive compulsive personality disorder is commensurate with avoidant personality disorder at 2.4% of the U.S. population in the National Comorbidity Survey replication, and a higher prevalence of 4.7% in a summary of epidemiological studies. The high heterogeneity of OCPD individuals is something to consider in assessment, considering qualities like perfectionism and rigidity are actually really common among other personality disorders. We then have to divide those qualities into subtypes, and perfectionism could include pleasing behavior or aggressive behavior. That perfectionism may be inflicted on others, it could be vindictive or self-serving, whereas pleasing perfectionism could be centered in self-doubt, low confidence, and fear of losing one's approval. And those would be different indicators for OCPD versus another personality disorder like dependent personality disorder. And all of that to say, there is actually quite a bit of overlap between OCPD and dependent personality disorder, not to mention a comorbidity with borderline personality disorder. Finally, risk factors contributing to the experience of this disorder include an association with strict parenting, and it's been identified how the strict environment in childhood can cause children to rely on that rigid obedience in order to obtain security. Again, with this personality disorder, structured interviews are an effective way of assessing, though it should be considered that the heterogeneity has to be a focus, and doing in-depth assessments that include self-report measures, observer report measures, and hopefully free response measures like the narrative TAMUS reporting tool will ensure that this diagnosis doesn't overlap with borderline, with dependent personality disorder, and then finally there's obsessive compulsive disorder to consider. The distinction between the disorder and the personality disorder is that the disorder implies distress from the symptoms. An individual experiencing a personality disorder that's obsessive compulsive is not going to be fazed by these practices and is going to identify them as normal for their coping strategy. Cognitive behavioral therapy, including exposure elements, is recommended for obsessive compulsive personality as well as the other two diagnoses. An interesting study identified how metacognitive interpersonal therapy, which is a branch of cognitive behavioral therapy, can be used for OCPD and avoidant individuals to identify factors such as understanding one's mental state, accessing their affect, and understanding their destructive self-evaluations using both individual and group therapy. DBT has also been shown to be effective for this population, and the primary focus in the study included here is maximizing openness, and as one of the primary 5 factors of personality, openness to experience can be identified as a growth area to guide the obsessive compulsive individual towards security without fixation on their prior stigmas. Finally, as with all of these disorders, but especially with obsessive compulsive personality disorder, the criteria that qualify one for the disorder resulting in the heterogeneity should be considered even when choosing a treatment modality. When we choose targets for treatment, we should consider that Aspects of other personality disorders could be part of our client's experience. There is a lot of overlap between personality disorders, even within different clusters. So it should be considered that personality symptoms outside the particular diagnosis could be a part of their presenting symptoms, and as a result, treatment could vary.